as secondary intention. But then we get a clean wound bed and it's still really gaping and we are able to actually bring it together under certain circumstances, then we can actually close it later on. That is pretty rare and not very common, okay? Primary and secondary intentions are basically like what we deal with on a day-to-day basis, okay? For primary intention, we want the wound to be less than 8 to 12 hours old. The older it is, the more likely we are most likely going to have a secondary intention type of healing, okay? Why do you think that is?
Bacteria?
Bacteria, absolutely, right? So if that wound is old, it's had a chance to accumulate debris and bacteria, and so then we would just be closing all that bacteria up into this like small, nice little warm, moist package that just makes it thrive, okay? Our risk of infection goes up exponentially. Okay. For secondary intention, right? We normally leave all of our stab and our gunshot wounds, so our penetrating wounds, and we normally leave those open. Why do you think?
They're already infected?
Bacteria, right? Do you think they're gonna get stabbed with a sterile knife? Or the bullets are sterile? No, they're all covered in grime and gun oil and whatever that rusty, knife is, or whatever, it is, okay? So no, we do not close those. We leave them open to heal by secondary intention, okay? The one big drawback from secondary intention is that it leads to these chronic wounds with poor cosmetic outcomes, okay? They will have a scar. We cannot help that, okay? But if it means a smaller scar versus closing it by primary infection, getting infected, having to reopen it, having to go to the OR and actually clean out more tissue, their scar is going to be bigger. Okay? So if we have to do it by secondary intention, we will. All right. What is suture? Suture is a foreign body by nature, or by definition. Okay? We have a bunch of different types of suture. I'm not going to make you know all of them, but we're going to go through the most common ones. Okay, so that when you get to your primary care clinic or your ER, you're going to know kind of an idea of what you would want and why. Okay? Suture will cause inflammatory response. It will interfere with wound healing. It does increase the risk of infection. Well, then why use it?
It's not getting closed otherwise?
It may not close otherwise. We can't leave every wound open to secondary intention. We're more civilized than that, right? So we have sterilized, so sterile suture, okay? And we can help mitigate this by the type of suture we use and where we use it and in what conditions we use it on, okay? So when we talk about suture, we normally categorize it by like material used, the tensile strength, whether it's braided or a monofilament, okay? Does it absorb in our body? Okay? Natural fibers will have a more intense inflammatory response. So like cat gut is an absorbable cat gut that's spun down into suture, okay? It will cause an intense inflammatory reaction, but it's very good for an absorbable type of suture. Okay, so in certain instances, we will pick that over another just because we know that this patient is never going to come back. Okay, if we were to put nylons in someone and they never come back, their risk of infection goes higher because we don't know if they're ever going to get them out. Okay, tensile strength, the biggest thing is if it's a larger number, means it's a smaller diameter thread. Okay, so a 1/0 silk is bigger than a 10/0 silk. Okay, 10/0 silk is extremely, like 10/0 nylon, 5/0 nylon is really the smallest that you'll find in normal clinics. Those are very, very small. Okay, they're used for the face, they're used for very small, intricate type of repairs versus like a 0/0, an 0/0. We use that to close up fascia in the belly. Okay, we may use a 1 or a 2 to help close up the belly. If we need something that has a high chance of breaking open because of where our incision is. Okay, like I talked about configuration, whether it's a single filament or multiple filament, twisted or braided. Okay, the biggest thing is braided has an increased risk of infection. Why do you think that is? Yeah, nooks and crannies. Crannies? No. Nooks and crannies, yeah, sure. Yeah, that, okay, so because of it has multiple lines to kind of find its way in instead of just one line, okay, it does have an increased risk of infection. Okay. The only thing with monofilaments, normally, especially the non-absorbent ones, it can be very hard to actually have it hold a knot. Okay, when we get to the suture lab, you'll kind of understand why it's very non-pliable. Think of like really thick fishing line. Okay, if it's already twisted in a you know spiel, whatever, I can't talk today. In a spool, it's going to contain that memory of being in or on that spool. So having it, you know, only do 3 knots, which we can do with a monofilament or a braided line, okay, that's gonna hold that knot more with just 3. With the monofilament nylon, the non-absorbable, it's gonna take more knots in order for it to actually hold that knot. Okay, so I want you to be able to read a package. Seems pretty simple, but unfortunately they make it very convoluted sometimes, okay, knowing where to look. So we can learn by the packaging, whether it's absorbable or non-absorbable, braided, monofilament, what's the size, and then all of the stuff with the needle, okay? So if you look at this echelon above here, okay, it's a Vicryl, it's an undyed braided, okay? It actually says down here, absorbable, synthetic absorbable suture, okay? It's a 3/0, so it's pretty big. It's 18 inches long, or 45 centimeters long. It is a SH or a taper needle. So you can kind of see that looks like a circle with a dot in it. Okay, the proline down here has a bigger circle and a dot. Okay, that is the shape of the needle itself. Okay, it's tapered. It's still got a sharp point on it, but it's tapered. And then the size of the needle on the package, they made it really nice for us, is the actual size of the needle in the package. It is a 1-to-1 size. Okay, so if you have someone who you are trying to close a smaller wound, you may need a smaller needle than that. Or if you're trying to do a bigger wound, you may need a bigger needle than that, depending on, you know, the area and all that. Okay, so to reiterate, this is the main 1, 2, 3, 4, 5, 6, 7. Oh, I forgot an arrow there. 8 things that you should know where to find. Okay, the size, the length, the type, okay, whether it's braided, unbraided, undyed, dyed, what type of needle, okay, the size of the needle, and then if it's absorbable or not, okay. If we look back on this one, the non-absorbable part is way down here at the bottom. And if you see 2 needles, it's actually called a double arm, okay. You're gonna have that length of suture that's 18 inches long, there's gonna be a needle on either side. Okay, we use those a lot for when we're trying to reanastomose bowel or blood vessels. Okay, not very common in the clinic, but there's nothing saying that if this is the only thing you have and you need this, you can cut off 1 needle and use it like a normal suture. Okay, all right, the needles themselves, okay? If you hear the word swagged, it means that the suture is pre-attached to the needle. Not very common in human medicine that the needle isn't attached to the suture, right? Or that you'll have a needle without suture. More so for veterinary medicines, they have that. But we will have needles, we will have suture that has no needle, okay? Normally it's silk vessel ties. Okay. And if we actually have some that are pop-off, okay? So if we know we're gonna do 10 or 20 in a row, we can just throw what we need to, pop off the needle, and then tie, instead of throw, tie, pop off, throw, tie, pop off. So it just depends on what we're doing, to just make sure that when you are actually looking at the packaging, if it says pop off or not. Okay? So when we're looking at needles, cutting is preferred for skin. Okay? So if you are trying to close a laceration anywhere on the body, you want a cutting needle. And what does that mean? Is that it comes to a point on the bottom or on the top of the actual needle. Okay? It's a triangle. Okay? Versus if we have a tapered or a round, okay, it's nice and round, there is no sharp edge on the needle itself. Okay? That would be more so for blood vessels and bowel. Blunt, which we really don't even see here. Basically, it's like a taper, but instead of that tip being sharp, it's blunt. Okay, it won't actually poke you. We use those a lot for solid organ like liver and spleen. Okay? And then that double arm, like I told you before. Okay? Reiterating the braided versus monofilament. Okay? Braided, multiple strands together, higher potential for harboring bacteria on the braids. Monofilament is smooth, but it's stiff, harder to tie, but less chance of wound infection. Okay? Absorbables versus non-absorbables. These are just the types, so it's not an all-inclusive list. Okay? So for absorbables, chromic gut, cat gut, like I was saying, monocryl is the most commonly used one for subcutaneous closures. Okay? Monocryl. Okay. And then Vicryl, it's braided monofilament or multifilament, and we use that a lot for fascia in the belly. It is very, very thick. It is very strong. It can hold up to a lot of tension. Okay. And then non-absorbables, these are the ones that are on the outside of the skin, except for silk. Okay. So if you have a non-absorbable, we want like Epsilon or nylon, same thing. Okay. And this is what the one we use most commonly for the interrupted sutures of the skin. Okay. Does that make sense? So if you are doing a subcutaneous closure, which we'll talk about, basically it's in the subcutaneous layer of the skin, so it's not on top of the skin, it's buried in the skin. Okay, we want monochrome, sorry. If we are just closing the laceration or the injury on top of the skin, then we want nylon. It's not buried, the whole thing isn't buried in the skin tissue, okay? And it'll make a little bit more sense if you've never sutured, it'll make a little more sense when we get through the next few slides, yes?
Is it so can you close the sub-Q without closing the epidermis, the external? Are you pretty much, if it's a full cut, are you guaranteed to be doing one set of
No.
monochrome and then a
No.
set of?
It depends on the depth.
Okay.
Okay, so if it is super, super deep, and again, I have like the next few slides are like the different types of suturing. If we have a super deep and we wanna make sure that we're closing up all that deep space, we're most likely gonna use Vicryl. Okay? There are times in which we don't want actual suture on top of the skin. Okay, so for like cosmetic stuff, or we know that they're not gonna come back and we'd like to actually remove a nylon thread. So then we'll close with monocryl in the sub-Q layer and use like Dermabond on top to actually close the wound completely.
Okay.
Okay. But yeah, does that make sense?
Yeah.
Okay. The only one that we use internally that is non-absorbable is silk. Okay? And when I say that, it is because this is what we use to tie vessels off. We don't want it absorbing. Okay? When we have a vessel that we are trying to ligate, okay, we don't want that thread to biodegrade, right? We don't want our body to eat it. So we use silk in order to, it's always gonna be there. It'll kind of scar in. Does that make sense? Because if it were to break down, whatever we did to repair that vessel or to ligate it would break down and they would re-bleed. Okay? Alright. So, when we are trying to suture something close, okay, it is the Goldilocks of suturing. We don't want it too tight, we don't want it too loose, we want it just right, okay? Too loose means that the skin is not actually gonna come together and you'll probably end up with an infection and or a wound that doesn't heal correctly. If it's too tight, okay, you're gonna actually probably cause tissue ischemia and have that wound edge actually necrose and die, leading to, again, poor cosmesis, that wound is gonna break open, it's never gonna heal correctly, okay? But if it's just right, you have just enough tension on them so that your wound edges come together, but you don't actually cause strangulation of that tissue. So we want a little gentle eversion of those edges, but other than that, it's just basically to help keep the edges up. So we want the edges of the skin to be just slightly everted versus inverted, okay? Because if your tissue, right, were to touch each other, this does not really heal well to itself, okay? So we want the cut edge to be slightly everted so that it's the raw edge to raw edge. Does that make sense? Okay. All right. So, suturing techniques. This is fun. Unfortunately, your suture lab isn't until the end of the semester, so you're gonna have to remember all of this. We'll go through it again the day of, okay? Biggest thing, you avoid pushing the needle through the skin, okay? You're not pushing, you're guiding, okay? It is a lot of wrist and finger movements, and when we get to the actual lab, you'll kind of understand what I'm talking about. It's a little hard to understand if you've never done any type of suturing. Who's actually done suturing in here? Most. Maybe I should ask who hasn't done any suturing. More than, okay, maybe 50-50 split. Okay, so it's kind of hard to explain. It really depends also on the thickness of the tissue, the dryness of it, okay? Your needle's gonna go through a little frail, very thin old person skin versus the sole of someone's foot, right? If it's really thick, hard tissue, you're gonna have a hard time getting through versus a very thin, delicate tissue, okay? So, not pushing the needle through the skin, but trying to guide it through is the key. Okay. We normally try to do what we call bites, okay, in 1 or 2 drives, okay? Normally, so if you were to do this one up top here, okay, if the patient or the provider who's holding the needle driver, which we'll go through equipment in a minute, if they were to continuously push this needle all the way through so that they never have to re-bite the needle, okay, that's 1 bite. Okay, so in and out, the other side of the wound is 1 bite. If you do in and then out the actual wound, redo the needle and then go in and out the wound bed to the other side of the wound, that's 2 bites. Okay, does that make sense? Alright. When we do this, we want to make sure that the spacing between the entry and the exit of that wound is the same, okay? So if you have a wound, you want to make sure where you go in and where you come out the other side are the same equidistance from that wound, okay? As well as depth, okay? If you were to take a huge, big, deep bite on one side and then a tiny little bite on the other, this one is actually going to overshadow the tiny bite. Okay, it's not going to end up being nice, softly everted edges. You're gonna have them be weird, okay? So taking the same bite, equidistance from the actual wound edge, and the same depth that needle goes through the skin, you're more likely to have a nice everted edge, okay? All right. This is just some tips when you're actually holding the needle with the needle drivers. Kind of looks like a hemostat, but it's not a hemostat, okay? We want to load. So if I go back to this one, see how this one's kind of like right in the middle, between like 50 and 80%? You know, you're not way back here where the suture is and you're not way up here. You kind of want to be in this 3/4 of the area, kind of in between. Does that make sense? So when I say 50 to 75, like that 3/4 between the middle and like back towards the suture itself, somewhere in there is normally where you're grasping that needle with the needle driver. Okay. We want to try to pull the suture through. We're trying not to touch or like grab the needle tip with the needle driver. We don't want to dull it, okay? And when we pull it through, we want to make sure we leave enough tail on one side so that we can actually tie it. Okay, if you leave yourself just an itty amount on one side, it's going to be really hard to tie. Okay, and the longer you do this, the shorter your tail can be. Just depends on how good you are. Okay, and we basically want to try to close the wound without any spaces or pockets underneath, because that can harbor bacteria and have seromas form and just be an area that can fester bacteria. Alright, so don'ts. Again, don't load the needle too far back, because as you go through skin, the harder the skin it is, the more likely you're actually going to bend that needle. Okay, these are not like titanium. They will bend, you will break them. And it really causes more of a safety risk for you guys. One is harder to drive the needle through the skin, as well as you can choke yourself. Okay? Pushing the needle through the skin instead of just guiding it, crushing the suture material, grabbing the needle, pulling the suture all the way through. You're not paying attention and you accidentally pull it all the way through, then you have to take the pull bite again. Okay? And then letting those wound edges invert instead of evert. Alright. These are some of the ones we're going to go through. Okay? This one we talk a little bit about during the suture lab, but we don't we can practice it. The one that's on here, the one that's not on here is a horizontal mattress, but we'll go through it. Okay? So, simple interrupted sutures. Okay? This is individual loops of suture along the length of the incision, or along the length of the wound. Okay? They're one or two bites, you tie it off, you cut, and then you do another new bite. Okay? With vertical mattress, okay, these are basically in the same line, okay, same line on the incision or on the wound, but you go in deep or like far, come out far, go in narrow, come in narrow, and then tie on one side. But they're all in the same line, okay? Versus horizontal mattress, you come in one side, you come out the other side, but then you move up a centimeter or half a centimeter, go in, come out, and then you tie to the one where you came in at. Okay, so it actually looks like there's two sutures, but it's really only one. That's horizontal mattress. Okay. Deep dermals is what I was kind of talking to you about with those Vicryls, making sure that if you have a really deep wound, you're closing that dermal space. Okay. This is where seromas like to form, or hematomas, and if you don't close that space, you're more likely going to have complications. The only difference is basically we do a interrupted, but upside down and deep. So your knot is actually buried at the bed of that wound. Okay? So you actually go in deep to the wound, come out to like the subcutaneous layer, go in the subcutaneous layer, come back down deep, and then tie your knot in the actual wound. Okay? That just closes everything up nice, deeply. And you can do multiple layers depending on how deep you are. Most of the time, you really only need one. Okay? Running subcutaneous, these are harder. Okay, but this is in that subcutaneous layer. Okay? And basically, you start at one edge of your wound. Okay? You kind of do a deep dermal. You do your tie, your knot is inside the wound, because none of the suture is out here on the top of the skin. Okay, so you tie your knot inside the wound, and then you kind of instead of going in, you're kind of more going like around the edge. okay? So you're never above the skin level. If you do, that's called buttonholing, okay, we don't wanna do that. So instead of going like in, you're actually going, or through the top, you're actually going through the side, okay? And you're kind of snaking it around in that sub-Q layer, okay? And then when you get to the end of that, laceration or whatever, then you can tie and bury that knot. So nothing is above the skin, okay? It seems more complicated than it really is. It's probably one of the easier ones to do. Okay, we're gonna go a little, through them a little bit more, individually, okay? So, simple interrupted. These are the single looped, tied, cut, move on, okay? Most commonly used suture technique in every external type of closure, okay? If we have a suture on the top of the skin, we can use a simple interrupted, okay? Now, if the wound is under a lot of tension, we may not wanna do this, okay? Cause we're only kind of hoping that wound edge, stays together with one single, suture at a time. Okay, so if one edge has more tension than the other, they can actually break these knots and have part of the wound open. Sometimes that's a good thing, right? If you were to have a running subcutaneous or a running deep dermal, or even a running, not interrupted, a running, simple. Yes, thank you. Were you a search for? No? Okay. Simple uninterrupted. It is Monday, guys, so give me a little bit of grace. So simple uninterrupted, basically you start at one end and you basically do this, but you go through the skin in a spiral and then you end. If one of those places were to break down, or that one line of suture were to break, then that entire wound is now open. Because it's not interrupted. Does that make sense? Alright, if you have one single long strand going through the entire length, if any part of that cut or breaks, the entire wound is gonna, what we call dehiss. The wound edges are gonna fall apart. Your repair is gonna fall apart. Okay? We normally leave simple interrupted for 7 to 10 days. Normally on the face we do a little bit less because our face heals pretty quickly. It's about 5 days. Okay? Normally we use nylon, and normally we use 4-5-6-0. Okay, the smaller of the types of suture. If we know that they are never gonna come back, so like if you have a homeless population, or they're potentially into the more illegal type of substances, and you just really don't think they're ever gonna come back to have these taken out, you can put in monocryl as interrupted, and they will just fall out on their own. Also great for kiddos. You know, you had to sedate them to actually repair the laceration. If they just fall out on their own, most likely you don't need to have them come back, okay, to fight with trying to take them out. Alright. This is where we talk about the horizontal and vertical mattress. Horizontal we really want for larger lacerations, so you can kind of see it has that bridge here and then, you know, but they're tied with one. So it's not as detrimental if one breaks versus the running uninterrupted, okay? But it has a great deal of tension, okay? And then vertical, we really do this for a lot of like super tense type of, like you're really trying to bring this tissue together, whether it's really swollen or it's in a region that is actually missing some tissue and you're really trying to pull it together, we will do a vertical, okay? Vertical normally take longer to place. Horizontal, sometimes is good as long, I mean, if you've never done it before, it's gonna take you longer either way, okay? But you can get good at both of these. Both of them we kind of leave in place for 7 to 10 days, okay? All right, running suture, or the uninterrupted suture. I was thinking of running. Okay, so akin to the simple interrupted, but you start at one end at the other. Okay, it's one contiguous type of suture. Alright. Easy to learn, pretty easy to do. The only problem is if, you know, the entire wound will be hissed if it breaks anywhere, like we talked about. Can be used for subcuticular closures or that buried closure. Okay. If it's buried, you have to make sure you're using absorbable. If it's on the surface like this, then you can use absorbable, or I would probably not use absorbable for this one. Okay, if it comes above the skin, I would just do interrupted. Okay, but if you can use nylon and they're gonna come back, that way you know that not one little piece is gonna absorb faster than the others and hit the wound quicker or break down that wound quicker. Okay, so if you're gonna do a running suture, I would probably use nylon or non-absorbable. Deep dermals, like we talked about, okay? Approximate deeper tissues prior to that skin closure, okay? This does not close the skin. This just closes the underlying cavity, or the potential cavity that we have, okay? You still have to do something at the layer of the skin in order to close it completely. This is just one step of closing that deeper tissue area, okay? Okay. All right, what other skin closures do we have? Steri-strips, they're great when they actually work. If you have someone who is sweaty, who is greasy, who uses lotion, never gonna work. Okay, so you really have to ask your patient and know your patient population. Okay, but basically what you want to do is kind of have that wound edge together, and you're just gently laying this sterile sticker over the top. You're not placing it and then pulling it over to close the laceration, okay? If you do, you're gonna get something like this, where you have tension, blisters on either side of the wound doesn't heal correctly, okay? That's not what this is for. This is for a wound that just comes together naturally. If you are having to put it together, they should get some sort of a suture. Okay, so this is just, you know, they have a cut on their hand or skin tag or skin tear. Okay, I love these for old people who fall and they get skin tag or skin tears. I kind of lay the skin back over after really good irrigation. I lay the skin back over and then I tag the edges of that tear with the Steri-strips, and it really helps keep that skin and the raw area covered, almost like their own natural Band-Aid. Okay, it works very well. As long as it's clean. If it's dirty and they have mud and shit in there, like, don't try closing that, okay? They normally fall off around 14 days, okay? If they come back to you before then and you notice that an edge is still coming up, but their wound is still pretty wet, just trim that edge. Use your little iris scissors, just trim that edge, okay? If they come back and it's completely open, most likely you have to then have it closed by secondary intention. So this is why we only really use Steri-strips as for very low tension wounds, or say they come and it's been 7 days and you take out their sutures, but it's just not really healed for where you really want them. Throw some Steri-strips on there, give it a little bit more oomph to kind of keep it closed while it's healing that last little bit, but it's not that initial 7 to 10 days of really high tense healing. Does that make sense? So after you take your sutures out, you can put this down and just help kind of push it along to it's entirely healed. Okay? All right, Dermabond. Dermabond is great. Also, just like with Steri-strips, it's basically super glue. Okay? It is sterile. Normally it's purple. The one thing that people don't understand is that it dries by patient's body heat. Okay, so if you're standing there waiting for it to dry, just waiting, blowing it, it's never gonna heal. Or it's never gonna dry. Okay, it actually dries by the patient's body heat, which is really cool. Okay? Makes the wound semi-water resistant. Not waterproof, but water resistant. Okay? Which helps, you know, when you have somebody who wants to shower, we still don't recommend them having a bath, but they feel a little less of that sting when they take a shower. Okay? Obviously don't use if the wound is compromised. You're not using this in conjunction with anything else in terms of suture on the skin. You can do this with deep dermals or subcutaneous, but if you have it interrupted actually going through the skin, you don't use Dermabond and you don't use Steri-Strips. Okay? Alright, and staples. Quick closures. Okay? Most of the time, we use staples in the ED if we want to try to hemostasis something really, really quickly. I have a picture of an example later on. We use it a lot at the end of surgeries for big belly incisions, X-labs, or ortho likes to use it for wide areas. It's very easy. We evert those edges, we clip, move on. Okay? It is very fun if you get to do it in the OR. Okay? Which, as students, you will be allowed to. So ask. But basically, you can kind of see, like, we have those deep dermals down here. We evert the edges with some forceps. We apply the staple, and then it just kind of puts pressure there. It's really cool. Okay? And in an extremis type of situation, this person has a huge head laceration and they're just bleeding. We can actually just staple across that wound, at least for now, to get hemostasis of that wound, because scalps bleed a lot. Okay, if we have other things that we need to go through, that can at least put a little bit of pressure on that wound quickly in the ED, so we can go on and do other life-saving things. But it will leave a more prominent scar. We try not to do it anywhere on the face. Okay. And they're more resistant to infection because it's metal. Okay, it's like that monofilament type thing. It's not braided. Okay, and it can be done without local anesthetic. I would say if the patient is stable and awake, and you have to do more than like 5, give or take a few, I would probably use anesthetic. Okay, but if you're just doing 1 or 2, you can have that conversation with that patient being like, hey, I'm about to poke you at least 2 times on either side of your wound bed to anesthetize you, or I can just do 2 quick little stings and then you're gonna be done. Okay, so it really depends on that patient, conversation with you guys. All right, these are needle drivers. These are the surgical instruments that we use that are designed for suturing. It holds the needle. Okay, it is not a hemostat. When you look at the hemostat versus the needle driver, the teeth on the actual end where the holds the needle is different. Okay? If I can find a good picture, I will. But I didn't have time last night. When you load, again, you're loading at that 50 to 75% mark. When you actually put your hand on it, okay, you are not putting your whole finger through the rings. Okay, again, we'll talk about this more so when we do the actual suture lab. But you're kind of holding it more so with like your fingertips and or your palm, not putting your entire thumb and finger into the holes, because you're not going to have as much dexterity that way. Okay. All right, forceps. Do not call them tweezers. Please do not call them tweezers. Okay, I'm trying to make you sound intelligent when you get to your surgical rotation. They're not tweezers, they're forceps. Okay, so there's 2 main ones. These are not the only ones we have, but these are the 2 main ones. Addisons, these are for outside the body. They have more of a rep tooth. Okay, they have one side will have 2 prongs, the other one will have just 1, and it's used to not crush tissue. Okay, it may pierce, but it's not going to crush it. Versus DeBakey's, which we use on the inside, really helps. It has many, many small teeth, okay, or ridges that will potentially, if you were to grab the layers of the skin, okay, you're actually going to crush that tissue and devitalize it. Versus on the inside, it's mostly like schmutz tissue. It's not really anything that we care about, okay, most of the time. Like, so DeBakey's for inside the body, Addison's for outside the body. Does that make sense? Kind of. Okay, good. You hold it like a pencil, not like a spoon. Okay. Again, we'll go over all this again when it's actually the, the scalpel, or suture lab, okay? There are many different types of blades, okay, but there's 3 that I want you to be aware of, and the numbers are on the bottom of each blade. Okay, so 10, big round belly, large incisions. We cut on the belly side of the blade, we don't cut from up here. Okay, so when we're actually cutting, we're not cutting like this, we're cutting more like this. Okay. 11, nice sharp point, we use those for INDs and to puncture things. Okay. Not necessarily used for making longer incisions. And then number 15 is very short. Again, we still try to cut on the belly of the blade. It's a very close cousin to 10, but it's very, very tiny. So we use those a lot for like smaller incisions, very delicate work, that kind of thing. Okay? All right. These are everything you should know. I'm not gonna necessarily give you a picture on the test and tell me what it is, because you guys are past that type of knowledge. Okay, that would be too easy of a question. But, these are all the different types of scissors. Okay? We have medicine balms, curved mayos, straight mayos. Basically, when you have a mayo, it's very similar to like a suture scissor. Okay, but these you can actually cut through like a heavy mayo. You can actually cut through the sternum with someone with a heavy mayo. Okay. Medicine balm, we use those to help actually divide tissue as well as cut delicate, fine little schmutz tissue. Okay, when we're trying to delicately differentiate and divide out like blood vessels and everything like that. It does not have a sharp. Although it looks like a sharp tip, it's not really that sharp a tip, it's kind of more rounded, but it does allow for us to get through tissue. Okay? These are some different types of forceps. On this side, you have a DeBakey. Okay, you can kind of see if you look real close, those edges are like ribbed all the way up. That will crush tissue, versus this guy over here is an Addison. This is a little bit bigger Addison. You have that rat tooth kind of formation. Okay? These are different types of needle drivers. Okay, if you really want to know the actual name, cool. If not, needle driver is just fine. And then when you have a small, I think this kit is actually the toenail removal kit. Because you have an elevator, you have some other things in there, like the big cutters. So every kit, whether it's a minor procedure kit, a laceration kit, a toenail removal kit, you may have clinics that you have to actually put these kits together. You may be able to get disposable ones. Just depends. Just make sure that when you're actually looking at that kit before you're opening it, actually looking through it to see what is actually in it, and is it going to actually do what you need it to do. All right. Okay. Pre-op prep. Everybody should know this from the last block. You get a good H&P, you get their medical, social history, their surgical history, past medical history, getting that informed consent, doing that risk benefits alternatives. Okay. The biggest thing, timeout prior to injection of anesthetic. Okay. So what does the timeout include? Basically your 5 rights, right? So right patient, right site, right meds, right imaging, right date of birth, whatever, right? It's making sure that what you are actually here to do, what the consent says, if it says right leg, mole removal, it's actually the right leg mole removal and not the left leg mole removal. That's what the timeout is. Making sure that the informed consent matches the procedure that you think you're about to do, and that you actually do the procedure that you're about to do. Does that make sense? Okay. All right. Positioning your patient for you and the patient's comfort is extremely, extremely important. Okay. I have a bad back from bending over constantly instead of bringing the patient up to me. That's me. That's on me. Okay. Both you and the patient should be comfortable. Now, when you're planning your incision enclosures, we try to do it along those natural lines, okay? If with the chest, right, it's a more linear natural line. If we were to try to close an up and down or a perpendicular line to the natural lines, it's more likely to be twisted open, or it's just, it has more tension, okay? Now, the only places in which that is the opposite is over the the flexor surfaces of a joint, okay? If you are cutting over the flexor surface of the knee, okay, the anterior surface of the knee, right? You're not gonna do a transverse or perpendicular to the knee, right? Although, right, because the natural lines are going up like side to side, you're still gonna cut up and down. Because if you were to make that cut side to side, left to right, they were to bend that knee, it's just gonna pop open. Versus if you make a up and down cut over the knee, right? If you bend it, it's gonna be kind of more so cause the patient pain so that they know they can't actually bend it. They're gonna have to work through it and probably do a little bit of PT to get through that skin to stretch. But that's why we don't, over the flexor surfaces, we don't cut with the natural lines, okay? Because if they flex it, they're just gonna pop it right open. All right, prepping the site, many different ways to do it. This is betadine, okay? I think they're wearing a glove, they should be wearing a glove, this is sterile, okay? Basically you start in the center, make circles, whether you're using chlorhexidine or betadine, you just make big circles. You don't ever go back to the middle or scrub this way. Throw that away and do another swab of betadine starting in the middle, working outwards, okay? If you miss a section, you don't try to go back and do it, you do it with the next pass. Okay, if you have to do one more pass in order to make sure you get all of it clean, then that's what you have to do. Normally we do about three cycles, okay? Draping the area, if you have a clinic that has fenestrated, meaning a hole in the drape, right? Comes that way with a hole in the drape, that's great. If not, this surgical person, we'll call him a surg tech, right? He basically took a blue towel and held it on either end of the, so basically if this was the blue towel, he's holding it on the opposite ends and it folds more so like this, okay? So you can actually do two of these or a few of these and have your actual wound in the middle here, okay? Where then you can have just blue towels all the way around and you kind of you've made your fenestration. Does that make sense? Kind of? Okay. But you still want to drape it, you still want to put a Chuck's pad underneath. Don't make your cleanup harder than it is, okay? So before you even start, you put something absorbent underneath them, clean them up, and then drape the area. We normally use about 2 to 4 drapes or folded towels in order to get the area sterile, okay? When you are putting these drapes, you are sterile, okay? You are in a gown, you're in a head covering, you're in a face mask, you're wearing your goggles, you're wearing your sterile gloves. You are sterile, okay? There are some instances, oh my gosh, today's been a day. Some areas in which you might only need to wear sterile gloves, or if it is a dirty wound washout, you don't necessarily need to be sterile. You can still use these blue towels to kind of help keep the other areas around clean. But if they are sterile, you can actually use this as part of your sterile field to help you put your, all of your instruments still sterilely next to the patient instead of on your MIG stand. Okay? Alright, take a 10-minute break, guys. And wake up, go get some caffeine. I know. Apparently I have too many stories. Okay, so, right, we prep the site, okay? The next step after prepping is to anesthetize it, okay? We have a whole other lecture, which is our next lecture, on which anesthetic to use, so we're not gonna go over it here. Okay, but basically you choose the right one for your patient, for your site, for whatever you're doing, whether it's you only need a short amount of time versus a long amount of time. Biggest note is that lidocaine has faster onset, doesn't last as long. Marcaine takes a little bit longer to really take full effect, but it lasts for a lot longer. So if you have something that you know is gonna be really, really painful, like a toenail removal, you might wanna use a little bit of like Marcaine in there to give them a little bit longer, like 4 hours worth of pain relief versus 30 minutes. Okay? Make sure that when you are actually anesthetizing the area, you insert the needle all the way in. You aspirate to make sure that you are not in a blood vessel. And then as you withdraw the needle, that's when you're actually instilling the medication. Okay? Take some practice if you've never done it before, but the biggest thing is you don't want to like inject as you push forward, because if you do actually hit a blood vessel, putting lidocaine into a blood vessel, once you learn a little bit more about ACS and ACLS, not good, right? If you don't want them to have toxicity, which we'll talk about probably tomorrow, you don't want lidocaine or Marcaine or any of those types of things in a blood vessel. It does not do well in our system, unless you actually need it, okay? For sub-Q tissues, okay, see how this needle's bent a little bit, 45-degree-ish angle? It is okay to do that for like a 27 gauge needle, okay, it's really, really fine, really tiny, but a little bit longer, okay? That way you can actually get that sub-Q without having to be really weird angles, okay? You just don't wanna make it more than 45, because then the risk of the needle breaking is higher, okay? All right. Now you're actually gonna do the procedure. Follow the planned incision, okay? Don't get there and be like, well, I thought I was gonna do this, and then now I'm gonna do this. Like, it just doesn't ever end well. So follow your procedure, follow your planned incision, okay? Incise through the skin. You're gonna control minor bleeding with most likely direct pressure, okay? Some clinics will have either silver nitrate, which we'll talk about, or a little cautery. You may need to do like a clamp and suture legate of any bigger vessels that you run into, okay? If you take anything off a patient, it goes to pathology, period, okay? When you're not specialists, you do not have a microscopic eye. You do not know whether or not that nevus or mole or skin tag has any sort of cancerous tissue in it. If it comes off a patient's body, it goes into a labeled container and sent to pathology. Okay, if your clinic has a specimen log, make sure that you are logging it and following up on it. Okay? And then when you have bigger wounds, mainly like intra-abdominal, intrathoracic, if you have something that has a deep space, okay, we're not using like normal gauze, okay? This blue line, this gauze is called a Raytec because it is radio opaque. That blue line will show up, as you can kind of see here on this x-ray. Okay, so if you have a deep, deep wound that you could potentially lose gauze into, you should be using only a radio opaque type of gauze. Okay, procedure note. Pretty self-explanatory. Patient identifier, so name, date of birth, time, date, time, diagnosis, what procedure you're doing, who your surgeon or assistant is. That could be you or your surgeon and you or whatever. And any anesthesia used and the amount. Okay, you have to put in how much of what percent, with epi, without epi, all that jazz. Okay? Describe in detail how you actually did the procedure. It's not I cut this thing off. It's I measured, I started here, I ended here, I go through step A all the way to end. So it's I cleaned the wound with this, with betadine or chlorhexidine. I draped the area in a sterile fashion. I excised the lipoma, used whatever suture to repair it to pull those edges together. The lipoma itself, the tissue mass was sent to pathology, and then basically estimated blood loss. Did you leave any drains, and were there any complications? Okay, did you cut a blood vessel? Did you need to ligate? Whatever. How did the patient tolerate the procedure? So what was the patient's before and after pain? Super, super important for JCO nowadays. okay? And then disposition, are they going home, are they going to the ER? Or what's your follow-up plan, okay, are you seeing them in 2 days because you had to leave the wound open? Did you close them and you just need to see them back in 2 weeks for suture removal and pathology review? It just depends, and then don't forget to sign it. Alright, cleanup, this is also self-explanatory, okay? Most of you were some sort of medic in a clinic and had to clean up after provider. Some of you. I know that I know you're out there, okay? Don't be that person, right? Don't be that provider. I know some of you have had to deal with that just, leaves the room a fucking disaster, okay? Don't be that person. So if you can help clean up, especially your sharps, okay? If your medic, your corpsman, whoever it may be, are like, you know what, no, I got it, don't worry about it. You have other, we're already behind. You go see the patient, I will take care of this. That's fine, as long as they're actually saying that. But you should be in charge of your own sharps. You know where you put them, you know what you used. Do not have another person handle your sharps. Okay? Because you put it underneath this one gauze or this lip of the blue towel because you didn't want to poke yourself. They don't know that. Right? Unless they were in the room with you, but even then, I would still take 2 seconds out of your day, gather up all your sharps and put it in a sharp container, and then if they truly want to do the rest of it, let them, but otherwise rinse off your instruments if they are, your reusable instruments. If they're disposable, get rid of them, okay? And then the other big thing is these red biohazards, okay? Actually use them correctly. The item has to be saturated with blood. Okay, you're not your gloves. It's not a little bit of blood on a gauze. It's not your suture container. Okay, whatever your suture came into. It's saturated with blood. They incinerate those bags. It costs money by weight. Okay, so only saturated blood material go into those red biohazard bags, or if it's grossly infected material, purulent discharge, whatever, but saturated, okay? If it's just a little bit, it can go to the normal trash. Alright, discharge paperwork must include wound care instructions, okay? You cut them, or did something to them, how do you want them to take care of it? Okay, and it has to be really, really straightforward because some of these people do not have a good reading level, or they don't know any medical whatsoever. So being kind of almost obtuse is what we need to be, okay? How often do we want them to change the dressing? What do we want them to change the dressing with? Maybe we need to send them home with a grocery bag full of supplies so that they're actually changing the dressings in the way that you want them to do it. Do you want them to do it 3 times a day, twice a day, only once a day, only after a shower? Whatever, right? You need to tell that patient what the instructions are. When is it okay to shower? Okay? Normally, after 12 to 24 hours, most people are okay to shower. Okay? Now, if we actually cut into them, most of the time we do not let them bathe or submerge in water until probably 2 weeks. Okay? So, I have had to say, no oceans, no hot tubs, no pools, no rivers. Don't go, tubing down the Cozumel, right? They don't understand. Well, it's not bath butter. You only told me I didn't have to bathe. You didn't tell me I couldn't go in the river. So submersion of that water, of whatever that injury is. And then another good one to know is that protection for 12 months. Okay, especially if it is an area that is in a sun-drenched area, making sure that they're wearing sunscreen if they do not want a scar. Some people don't care. Some people don't care. But if they really want to avoid a scar or a worse scar, use that sunscreen, use that sun cloth, the clothing, the shirts or whatever, the t-shirts, for at least 12 months while it heals. Just the way the wound bed heals, okay? If after, because if they get a really bad burn between, the incision to 12 months, most of the time they're going to have a worse scar, okay? Signs and symptoms of infection, when to return, okay, or when to go to the ER, and then follow up. Either it's routine, urgent, and don't forget to give a workers' pool excuse if we need to. All right, wound packing. So these are for the secondary intention type of wound healing, okay? These are normally wet or damp to dry or dry to dry, okay? That meaning what's in the actual bed, wound bed is either wet or damp. Normally I want damp, I don't want it saturated, I don't want it sloppy wet, but a little damp. That way it's, when we actually pull it out, it's actually debriding the bottom of the wound bed. It actually helps that healing faster, okay? We don't normally do dry to dry too much unless it's already a very wet, oozy, weeping type of wound. Okay, again, we do not use dressing sponges. Okay, they have these microfilaments. You'll know because you'll like try to manage them and like little pieces of fuzz and like lint will fall off of these gauzes. Versus if it's actually a gauze sponge, it's like cheesecloth. It doesn't fall apart unless you cut it. Okay, but they're not going to have those microfilaments, or so that's for inside. And then the Telfa is a non-adherent pad that you can put over it that's not going to stick to the skin. Okay, so when you have burns or skin tears or something that is a very shallow wound, you don't want like this. The gauze is just going to drive to that scab, and every time you take it off, it's going to pull that scab off. Versus Telfa, it has a nice like Band-Aid like or a shiny covering to it that limits the amount of it to stick to the wound bed. Okay, so it'll still heal and have a nice scar underneath, but it won't pull it up every single time. All right, negative pressure wound vacs. Okay, we use this for very large wounds or very wet wounds without infections. Okay, we really don't want to have infections, or else we're going to do a wet to dry to try to clear up that infection. Okay, but these are wounds that are very large. They're very, very painful to do the dressing changes every day or twice a day. You know, or they are just weeping with serosanguinous fluid, body fluid. Okay, so you have the actual wound vac itself. Okay, you have the canister on the side of the wound vac, and then you have this long tube that then connects to the basically over top the wound. And what that is you have the wound base, you cut, this is kind of like crafts, okay? You cut this black sponge to the shape of the wound, you cover it with a crap ton of like Tegaderm or like clear protective like dressing, cut a little hole into the sponge, or the dressing over the sponge, and then this is called a little lily pad where the tube actually attaches, you put it over that hole, and then it's going to suck and actually push down, like suck all the air out of that sponge and constantly pulling that fluid, that excess fluid away from that wound bed. Okay, so it keeps things really, really dry in a non-infected wound that's really has a lot of weeping to it. Okay, you will have people who show up to clinic in these, okay, for post-op or whatever. If they come back and that sponge is not compressed down, everybody has seen those compressed towels that like come into a pill form, right? You get it wet and it spreads out into a nice towel. You want it compressed.
Call it nice, but
right? You want it compressed. If it is up like this, okay, that is wrong. That is a wound vac that is leaking somewhere. It does not have a good seal. So this is what you're trying to avoid. Okay, or you might have that as break before you're trying to like change it. Okay, that is no longer on suction, and we don't want it like that. This is continuous suction. Okay, they go home with these wound vacs, and it is constantly 24/7 under suction unless they're showering in 30 minutes plus or minus to be off of suction a day. But we really want to be keeping that 24/7 suction to then help, and really it does help that wound get smaller, because you're constantly pulling away that fluid so that wound bed has a chance to actually heal. Any questions on wound vacs? Cool. All right, silver nitrate, it is a chemical cauterization, most widely used for hypergranulated tissue. Okay? Basically when we have tissue that overgrows Above the level of the skin, we can use some silver nitrate to help like stun it back to a normal tissue composite. Or if you have skin tears that are, you know, constantly bleeding, constantly cracking open, you can silver nitrate the top of it to try to help get that wound expedited. But know that, you know, this black, right, may actually stain the skin. So I would not use this on the face. I would not use this anywhere that cosmesis might be a problem. Okay, you might actually be left with a black mark on the skin as the skin heals. All right. This person came into my clinic, into general surgery clinic, asking for help. I'm not exactly sure what happened. I'm not exactly sure. He said somebody repaired him, but obviously you can see that that wound edge might have been one of those like big bite, little bite on one side, and it just kind of tried to heal as best as it could, but it left that huge gaping hole in the middle. Okay, so we sent him to plastics for them to like cut into that, lay it back down, and try to fix that defect. Okay, so that was on the back of his scalp. All right, this person, so why too much tension and wound breakdown is not good, leads to wound dehiscence. This person had, I don't know if you've had it in derm yet, HS, the hydronetic suppurativa. Okay, basically it is an overproduction of bacteria causing chronic boils and stuff in their armpits and in their groin. This person had, basically this is their armpit, okay? And they, I don't know who hacked him, but it, along not natural lines and under so much tension because they took tissue out, they took all of those sweat glands out, okay? But they did a lot. They did a very extensive cut, and basically so much tension meant that most of his wounds broke down and he hissed. So we had to have these heal by secondary intention. It was very painful for a long time. So when you're planning your incision, making sure that you're, unless it's over the flexor surfaces, that you're not having too much tension. Okay? Alright, this is another one that I did. I didn't do this one. I followed up with him in the morning on the trauma service. This guy took a header backwards down the stairs, drunk. Basically the ER did what they needed to do. He was bleeding heavily out of his scalp. They really clipped, you know, very quickly clipped or stapled that shut so that they could do the rest of his exam. Unfortunately, didn't come back to it. So thankfully it was still under that 12-hour time frame. We numbed him up, gave him some fentanyl, took out all those staples. He had a huge hematoma under that skin flap. Cleaned it all out, did some deep dermals so that the skin didn't collect another pocket of fluid, and then restapled it. Okay? You're okay to do that. Okay? And most of the times this is why we do tertiary exams when we're on the trauma service, because then we find stuff like this. This will never heal. Okay? This will never heal correctly. All of this dark tissue in the middle is all hemostat, like all blood, like clotted blood and hair. Okay, and it was the edge of a huge hematoma. You can kind of see like this staple up here isn't even, it's only in the skin. It's not even traversing the wound. And these guys are just barely hanging on like a thread. Okay, so this wound would have never healed correctly. He would have had very, very poor cosmesis. His hair would always be like grow in funny. Okay, now granted it's the back of a guy's head. You know, we can fix it by growing his hair out a little bit, but we try to make it as nice and pretty as we can when we can. Okay? Alright, follow-up appointments, super, super important. They may come to you before they come see their surgeon, or you may be their follow-up appointment because you're the one who took out their lipoma, you're the one who took out their skin tag or mole or whatever biopsy. Okay? The only thing, I know I said everything that comes off a patient needs to go to pathology, except toenails. You do not need to send toenails to pathology. okay? Unless it looks real funky, but you don't necessarily need toenails. But getting that pathology report prior to them coming into the room, okay? Remember to ask them how they are. How is their pain? Did the pain control that you gave them, was it enough? Okay? Any complications that they had, make sure you document it. Again, pain control, reviewing that pathology report with them in words that they understand. Okay? Make sure you examine your surgical site, your procedure site. If it's time, removing the staples or the suture. Okay? If you see somebody following up for something and they've had an X-lap 10 days ago, do not take out their midline sutures. We normally leave those for a good 2 weeks. Staples. We normally leave midline abdominal staples after an X-lap for 2 weeks, 14 days. So if they show up in your clinic for whatever reason, say they want to be on, put on Limdu, or they want their hypertension meds refilled, whatever, don't take out those staples. Okay? Make sure that you are asking for concerns and asking if there's any follow-ups or referrals that you need to, and then follow-ups. Alright, suture removal. We'll practice this again on the suture lab. Make sure that the area is clean, that the sutures are loose. Okay? Remove sutures with scissors, little iris scissors, or they have actual suture scissors that have a little cut out on one side, like a little divot on one side that you can actually loop it and then cut it. Okay? Unless you have a super steady hand and the patient is old enough that will sit still even if they're in pain, which is no one, okay? Do not use a scalpel to try to remove a suture. They're gonna flinch as soon as you start, screwing with that suture, and then you might actually cut them. Don't do that, okay? It is something that you can use in a pinch, but again, really have that forethought of like, are they actually gonna sit still? Do they have a good pain tolerance? Okay? Lift that suture off the skin, cut one side, and then make sure you get the entire suture out. Okay? You may have people who follow up with you, especially on your surgical rotation, that you weren't actually there when the surgeon put in those sutures. Okay, hopefully you read through their operative note, and you can kind of follow along, like, oh, this is a running note, this is a vertical, this is a horizontal mattress, whatever, and then you can kind of figure out how to remove it. But there have been some times where I didn't know it was a running, and I kept having suture come, and it just didn't ever stop. Okay, so knowing what type of suture, knowing what type of suture technique they used, very important. Okay, again, remove the entire suture. Staple, easier. Okay, biggest thing is you want to make sure that the two prongs are on the bottom, underneath the lip of the staple. Okay, that means that there are two prongs up, one prong down. That'll actually bend the edges of the suture or the staple outward and out of the skin. If you do it backwards, okay, it's actually going to push the staple further into the skin and cause them pain. Don't do that. You can use a hemostat to get in there and then spread them apart. But if you have a staple remover tool, that's even better. All right. If they come to you and the wound is infected, remove all the closures, whatever it is, suture, staples, steri strips, glue, whatever. Then you have to irrigate your wound bed and then redress it. In terms of, are you packing it? Okay, is it shallow enough that you don't have to pack it? You can just kind of put gauze over it, but you're not reclosing it. Okay, you're leaving that open. That's called source control. You're getting that entire abscess out, irrigating it, and then letting it close by secondary intention. Okay? If you feel like there's cellulitis present, meaning surrounding areas red, hot, fluctuant, or indurant, okay, and cellulitis is present, they probably need IV or some sort of antibiotic. Okay? If it is if you caught it early enough and just opening up that wound and gets you source control and there is no spread of infection, you may not need antibiotics. Okay? What really needed to happen is opening up and getting source control. Anytime that you think that, and especially if it is not your surgery site, okay, before you touch it, I would call their surgeon. Okay? There is such a thing, as surgical site infection rates, and sometimes we get a bad rate, or a bad rep because, people who don't know what it's supposed to look like, thinks that it's antibiotics and it's not like a allergic reaction, right? Which, if you remember this guy, see this rash around the dermabond? That's a rash. That is allergic dermatitis, contact dermatitis from the glue. It is not infected. Okay, but if you can't tell the difference, call their surgeon or have them go to their surgeon's office. Okay, so remember, don't reclose the wound. Call the surgeon so that they can make sure that they're following that. And again, do not assume all wounds are that are irritated are infected. If there's any doubts, send back to the surgeon. Okay. You need to be able to tell the difference between allergic reaction, inflammation, and infection. What do you think that is?
Infection? Can't tell if the white spot looks like pus or not.
Yeah. There's a little bit of a white spot there. So this lady had a lumpectomy and she was following up with me. This was just a few days after her procedure. This is actually an allergic reaction. The little white spot is a fibrous material from the wound still being very new. Okay, yes.
Did you just ask them, hey, gotta take a picture for the picture
Yes,
purposes?
I got patient for, yes. Plus, you do not know who the patient is. Okay, but yes, I got permission to take the picture.
That's
I got permission
Cynthia.
to take it.
I remember
Actually, the
those
guy that I
nails
fixed, I
anywhere.
actually got a coin. He was with a 5.6, I think. I don't know. I can show you the coin, but it was a very special secret squirrel. I don't know. But yeah, but anyway, so yes, this is an allergic reaction to Dermabond. That little piece of white is just fibrous material from the wound actually healing. Okay? So yeah, not infected. Alright. These are the types of procedures that you can do in your clinic. Okay, we have lipoma removals. Limited. Okay, they are normally bigger than what they seem. Make sure that you are getting either a ultrasound of it or some sort of an imaging study, because a lot of times they can be a lot more vascular than what they appear, okay, or deeper than they feel. So really have a good surgical plan. For EICs and sebaceous cysts, okay, EICs smell horrible. Okay, it is basically a collection. It is a hair duct that is clogged, a pore that basically has keratin and infectious and dead skin cells and everything, and it's a hard lump. Most of the time, these go and they are even years. You know, people show up after a year or however long, they're like, yeah, it's finally becoming irritating, I just want it gone, right? Then you have to get this entire cyst sac out or else it's just gonna reform. Okay, so EICs and sebaceous cysts, so EICs are more like firm, dry material. Sebaceous is like of the sweat gland. Okay, so they're more gonna be like a fluctuant lump. Can be confused with EICs, and a lot of times you will not know until you actually cut into it. You're like, yeah, that's sebaceous, or yeah, that's really gross and smelly and EICs. Okay, it could also be an abscess, but most of the time abscess will have other signs and symptoms. You know, redness, swelling, pain, fevers. Okay, it'll be more acute versus these guys take months to years to really develop. Hilar cyst is just a EIC but on the scalp. Toenail removals and then removals of nevi, moles, and skin tags. I will check with EM to see if you guys actually go over these and like how to do them. I don't know that you do. I normally do not teach how to do them, but is that something that you guys would be wanting to do?
By
Okay.
do you mean like
I will
try
probably,
to do a lab with one?
we can't do labs with them,
Oh.
unless you have a sebaceous cyst you want to take it on, right?
I was-
So
I
I
don't
can't
know
really do
what kind.
labs, but you'll still do excisional, you can still do lips biopsies, on your pig feet when you do the suture lab. But in terms of like going over steps, I will try to fit it in our third block. There's a lot of overlap with EM, your third block, so I will try. I cannot guarantee, but I will try. Alright, this generic procedure go by from start to finish. Okay, it does not have the all encompassing everything, included in the actual procedure, but like setting up, and what you might need. Okay? These are some instrumentai videos. We will watch them in our suture lab, okay? Now, before our suture lab, I'm just gonna say this now. I know our suture lab isn't until the end of the month, or end of the semester, really. At some point before your suture lab, watch these. Okay, especially if you have never done sutures before. Cause if you can watch it a few times, kind of, get a little bit of a handle on it, when you actually come to do the suturing, it'll go a little bit easier. Okay, if you watched it a couple times prior to, it's not brand new information with a pig foot in front of you, like, what am I doing? Okay, it just kind of helps ease into it a little bit more if you've never done it, and if you've already done sutures, these are good review videos. Okay, this is another one, kind of just going through like the first bite, second bite, going through the 90-degree turn, okay, everted edges versus this is not closed enough. And then the thing up here is basically helping you kind of figure out where you want your wrist to be when you're actually attacking the bite, okay? If your hand is already here, it really is hard to do more of a bite versus if your hand is here, it guides it a little bit easier. It'll make sense when you actually have it in your hand, which is why I put this as more of a review slide than something you need to know for right now. Okay? Alright, we have 20 minutes. Let's see how much with the other one we can get through. It'll make the rest of the semester go by quicker if we can get this done. Alright, so anesthesia. Okay, so there's differences between analgesia and anesthetic and anesthesia. Okay, when we think of analgesia, think of pain relief, but you're not going to lose consciousness, most likely, and you're not going to lose loss of feeling or movement. Okay, now if you take enough fentanyl, you're going to probably lose consciousness. Okay, but when you are given it in a normal, moderated dose, you get analgesia. Your pain goes away. Okay, versus anesthesia or anesthetic, you are most likely being put under sleep. Okay, but it is defined as without sensation. Okay, so analgesia, pain relief, but you still have your feeling and movement. You're not numb. You're not paralyzed. Okay, but with anesthetic and anesthesia, you have loss of sensation. Okay, you're numb, whatever, or you're asleep. Okay, now depending on where we actually put said medication, really depends on what effect we get. Okay, generally anesthesia, you're intubated, you're asleep, they are completely out. Okay, you are under so much anesthesia, general anesthesia, that your whole body is relaxed and we are breathing for you. Versus, we'll go through some central catheters like spinals and epidurals, where basically it either depends on where it is. We can actually leave a catheter in your epidural space and continuously give you pain medication so you don't feel from that level down. which is common in labor and delivery. Okay, so we can do digital blocks, meaning you just don't feel your finger. We can do local anesthetic around an area that we're gonna be working on. Okay, it definitely has a lot of uses. Okay, I want you guys to know this because these are just some very common, like when you say altered level of consciousness, propofol, etomidate, okay, anesthesias, analgesia, opioids, okay, ketamine, Tylenol, okay, amnesias and analytics, those are gonna be your benzos, like your midazolam, your Versed, okay, it's gonna make you, have less anxious, you may actually be in a twilight type zone, okay, may actually have you forget. Ketamine is kinda also an amnesia, okay? Muscle relaxation is different, muscle relaxation is your paralytics, okay? Fentanyl, sure it's gonna make you more relaxed, but it's more so because you're unconscious. Versus a paralytic, you can be awake and paralyzed. It's scary. It's called the silent screamer. Okay? So that's why we anesthetize first and then we paralyze. We make sure that people are asleep, unconscious first, and then we paralyze you. Okay? And then adjunct anesthesia, dexmedetomidate, though that is the Precedex, which is really, really common now in ICUs. Okay, you'll see that. It is, we use it a lot also for alcohol withdrawal. Okay, just kind of helps bring down, we can actually do low dose titers of a drip, and they can actually be awake and their tremors and everything is kind of controlled. Okay? Alright, so what is the mechanism of action of a local anesthetic? Okay, they are weak acids. Okay, they block the sodium channels and basically impair the propagation of action potentials, okay? So, basically they kind of attack those channels and basically block everything so you really can't get those action potentials to actually fire, okay? If the tissue is infected, so say you're trying to anesthetize an abscess, okay, it's an infected tissue, most likely not gonna work as well, okay, because it's more of an acidic type of environment. You may need even more anesthetic, or you may just not be able to really anesthetize the area as well as you would like. Okay, but unfortunately, we still have to do that IND. Okay, so ideal anesthetics, we want short latency, we want superior penetration, meaning it's actually gonna get into the area that we actually want to anesthetize. Non-addictive, completely reversible, low toxicity, stable, water soluble, non-irritating, and inexpensive. Those are the ones we want. Okay. Classifications. In terms of local anesthetics, these are for local anesthesia. Okay, this is not widespread. You can use these for digital blocks and regional blocks, but most of the time and for your case, it's gonna be either digital or local. Okay, the two I want you to know are lidocaine and bupivacaine. Okay, I want you to know the durations, because if I tell you I need something that, you know, is gonna be on board for 4 hours, which one are you gonna pick? It's not gonna be lidocaine. Or it's gonna be a mixture of lidocaine and bupivacaine marcaine. Okay, that's what I want you to know. Okay, how do you know if it's a amide? Okay, I comes before the cane. So there's an I before cane and lidocaine, there's an I before cane and bupivacaine. Okay, those are the most commonly used local anesthetics in general surgery and in clinics across the world. Okay, that's why those are the two I want you to know. Alright, during an instrument-integrated procedure, you note that the local anesthetic is ineffective at numbing the area. What is the most likely cause of this ineffectiveness? Who wants 1, 2, 3, 4, 5. Who's just done? Okay, so anybody who picks cellulitis, you're correct, right? Infection makes it ineffective. Okay? Everything else should not, I don't think there's anybody immune to lidocaine. Okay? Alright. So what is the advantages of adding epinephrine to it? Okay, epinephrine by itself is a vasoconstrictor. Okay, so if you have a wound that is bleeding a lot, like oozy, right, and you can't really get control of that blood to even repair it, use lidocaine with epi. Okay, it's gonna vasoconstrict that area. It's actually going to increase the duration of action, so it actually lasts longer. It stays in the tissues longer, okay, because all blood vessels are vasoconstricted. It's actually gonna help the bleeding, gonna bring some hemostasis to it, okay, and you don't need as much. Okay, because normally lidocaine will go into those tissues and kind of diffuse into the surrounding area, so you need more. But with epi, you kind of, because of that vasoconstriction of those small little capillaries around the wound, it stays in that area more concentrated and for longer. So that way you don't need as much, okay? Disadvantages though, if you use too much or get into a blood vessel, you can cause tachycardia, hypertension, and dysrhythmias. Not good, right? So this is why we, insert, aspirate, make sure we're not in a blood vessel, and then instill as we draw out, okay? And then, somebody who is like cardiopath, so like really bad heart disease, hypertension that's like super uncontrolled diabetes, and hyperthyroidism, I would try to avoid epinephrine in them, because it can really exacerbate their issues. But if they are controlled, right, they are very low, they're, diet moderated diabetic, don't use to the max amount, but you can still use this in those patients. It's mainly for those who are like really uncontrolled, okay? And then the main thing is tissue supplied by end artery, so, fingers, toes, ears, nose, toes, okay, or penis, okay? Now, theoretically, if you're doing a digital block on a finger or toes, and you're doing it more here where it has bigger blood supply, you could potentially use epinephrine if you have someone who's like on an anticoagulant and they're gonna bleed a lot. But if you're doing like a very tip of something, like say you're doing just like nail or a paronychia, right? And you're just trying to do the surrounding tissue, I would not use epinephrine on the very tips of things. Okay, but if you're doing digital blocks or regional blocks, you can do a little bit more. What time is it? Oh, you guys, 7 minutes. Okay, local hypersensitivity reactions. Okay, most common side effects: urticaria. What's urticaria? Hives, right? Wheals. Okay. Erythema, edema, and dermatitis. Okay, if you start to instill it and you turn around and see that, you stop. Don't try to cut into that. Okay, we're gonna have to use something else. But I would not try to, if the tissue is already red, it's swollen and really inflamed, okay, do not proceed with that procedure. Okay, treatment, we give them oxygen fluids, antihistamines, steroids, if it's really bad, okay? And then if it's a really bad anaphylactic type 1 type of reaction, we give them the EpiPen, okay? Which seems a little weird, but that's really for lidocaine, not with epi. But still, we're still giving epi for anaphylaxis.
The cure to epi is epi.
Okay, so toxicity. Say we give too much. What should we be aware of? Okay. Prodromal symptoms. So they can have circumoral, so mouth tingling. Okay. Tinnitus, ringing in the ear, lightheaded, dizziness, metallic taste in the mouth. Okay. If you start to have that and you really don't do anything and you start giving them more, then it can lead to cardiovascular toxicity with hypertension, which then leads to hypotension. Okay. Tachycardia or bradycardia, VFib, and then cardiovascular collapse and death. So you want to be watching out for these. Okay. And then again, severe CNS toxicity, you can have an actual tonic-clonic type of activity, so a tonic-clonic seizure, altered, altered or, loss of consciousness, okay? And then unconscious, and then death, coma and then death, okay? So this is not something to just like, forget about, like you really want to make sure that you are calculating the max dose that that patient can have and that you are not going anywhere near it. Because that's something that we cannot defend you on if you have a sentinel event and you kill a patient because you gave them too much lidocaine. Which brings us to calculations. How do you prevent it? Okay, aspirate prior to injecting, always. Okay, always. Aspirate before injecting. Make sure that you are not in a blood vessel. Okay. When you're doing lidocaine, and lidocaine without epi, the max dose is 300 milligrams. Okay, that's the max dose. Okay, but you still want to try to figure out that patient's max dose with the 4 milligrams per kilogram. Okay, if the max dose of any one patient on their calculation is 500, are you going to give them 500?
With
No,
epi.
their max dose is 300. Okay, and same thing with lidocaine with epi. Okay, their max dose complete is 500. But their personal max dose is 7 milligrams per kilogram. Okay? So if I were to tell you they have 1% lidocaine, which has 10 milligrams of lidocaine per ml. Okay? So we already gave them 10 mLs. That's 100 milligrams. Okay? And I want to know, it's without epi, I want to know how much more I can give them per their weight. Let's say it's 100 kilograms, you can have 7 or 100 kilograms, 400 milligrams, right? Am I going to give him up to 400? No, he maxed out at 3. I would know how to do this for the test. Anybody who's asleep, I would know how to do this for the test. It's an easy answer. Okay. Onset, 2 to 5 hours. Or 2 to 5 minutes, sorry. Duration, half an hour to 2 hours. Bupivacaine, okay, because it is more concentrated, it is more potent. 2 milligrams per kilogram up to 100 milligrams. We do not recommend it for anybody under 12. Okay, onset takes a little bit longer, 5 to 10 minutes, but duration lasts up to 4 hours. What do you think?
4.
So 10 mils of 1% epi with lido, lido with epi.
Is 100 milligrams.
100 mils, or 100 milligrams. Okay, what's the patient dose with epi?
500.
7 mils per kg. He's on 100 kg, so his max personal dose is 700. But which one are you doing?
500.
500, very good. All right, we'll stop there.